Thank you, Ike, for that, and thank you, Larry and MST, for allowing me to be a part of this program. I think it's been a phenomenal experience for me to be involved with the work that Larry and the entire folks at MST do. As Ike said, I echo his comments. They are really hands-on. They want to hear what you're thinking, what you need, and it's been a fabulous experience for me. Lots of different prototypes, fun to move forward with them. Having said that, I'd like to say that then these are my financial disclosures, and we can go on. Just bring up the next slide, if you would, please, and or I can do it from up here. There we go. So, you know, I thought that Ike asked me to speak first. I thought that I would basically take you to a case that is not esoteric. It's not out there. It's everything that you deal with every week, week in, week out, throughout your day-to-day working with cataract patients. And it's a patient that you're going to deal with on Wednesday when you're back at work, or Tuesday or whatever. And this is an 82-year-old gentleman who simply has developed cataract. He can't see road signs anymore. I can't believe sometimes what these people come in here, come in the office with, suggesting that they're still capable of doing it. And you look at what they're able to see, and it's surprising. But his best corrected visual acuity in this eye is 2400. And he has poor pupillary dilation for no good reason, just exactly as you folks see in your practice. And he's got, so I put in quotation marks, the 4+ NS cataract and the lousy pupil, and with a lousy red reflex. And so this is really a very simple story, Ike and Mike, and it's everything that comes along in the day-to-day workings of what we do. But these present the scenarios that get our backs up a little bit, and you look at this case under the microscope, and here's what you're looking at, and you're thinking, you know, what am I in for here? How might I improve the comfort level doing this case? It's like an analogy Tom Samuels would say yesterday. You know, I could do this case and sit in row 38B and fly across the ocean, or I can sit in first class 2A. And what's going to be the difference and make my comfort level that much better in this particular case? So any comments at this point from you guys? I mean, this is pretty routine stuff.
Well, clearly the pupil's pretty small, the lens is pretty dense. I'd also like to know if he's like my patients that usually show up like this and has a little bit of a tremor and a leg twitch.
Right. So, you know, when we look at the small pupil case, and the density of the lens certainly has some impact on what we do to manipulate the pupil. I like to be a minimalist in general. You know, what can I get away with? I think we all have our own, you know, comfort level, what pupil size. So very quickly, I'm going to decide what instrumentation or what tools I'm going to use to get that pupil of adequate size. But before even that, the couple things I really look at is what's the cornea like? You know, what's the endothelium like? I'm concerned that there may be some issues with regards to that, and also the anterior chamber depth. You know, whatever tools we use, whether they're pupillary rings or hooks or other devices. If the anterior chamber is very shallow, it can make the insertion and extraction difficult. So those are some of the things in my mind I would think immediately right off the bat that may not be typical thinking in terms of just an average small pupil case.
Great. Well, I mean, you guys nailed everything that I'm, you know, bouncing in the back of mine. Here, I want a view. I mean, it would be nice to have a better pupil than this. Someone would say, well, I can do that case with that pupil. You know, I might get away with it. But, you know, it's not about getting away with it. It's about getting to the next patient. The reflex is going to be crappy, as you can see here. Lens hardness is another issue. How are you going to deal with that? And I said exactly right. You know, the corneal endothelium, what we call the collateral damage. What else am I going to do to this eye while I'm working on this patient's cataract? So these are the issues in my mind that absolutely go bing, bing, bing when I look at a patient like this. And I think about what are the best ways, what are the things I'm going to do to make these issues less of an issue, so to speak. Does that pretty much cover what you guys are thinking at this point? Anything else to add there?
Well, you know, it's interesting that you comment, you say, well, you know, maybe I could struggle through and get through with this size pupil without doing anything. I think it would be perhaps interesting for the audience, do you have a threshold that you say, gee, I think this one I'm going to struggle through, or this one I think I'm going to go ahead and use some augmentation from the start?
Threshold, I mean, if you have readily available instrumentation that you're familiar with and comfortable using, why make that threshold where it was here when it can be down here? You know, I mean, I'm just saying, make it the easiest case you're going to do in every possible way. It's not going to be the easiest case, but make it as easy as you possibly can. So you know, what do I want in my, you know, armamentarium, my artillery? What am I going to think about? And this is already written on the OR line. This is on the, you know, this is going to be on the OR schedule. All these things are going to be listed. So when I look at the OR schedule, I say, I'm going to the next case, I see what's listed as the things I'm going to possibly use. So I already know about the case. I'm prepared, and I'm thinking, okay, great. These are the stops that I'm going to pull out. So in this case, the Malyugin Ring for not just pupillary expansion, but pupillary stability, iris stability. I want to take the iris completely out of the picture. I'm going to have enough to deal with in the hardness of the lens and the view and getting the rexus done and all the rest of it. So let's eliminate one contentious issue. Boom, take the iris and pupil out of the picture. Number two, trypan blue dye. Absolutely. If I'm going to have trouble seeing the rexus, I want a rexus. I want to make it a controlled rexus. I want it the size I want. I'm going to use that. What I'm going to do about my phaco settings, I adjust my parameters. I think about what settings I'm going to use for different stages of the case. And as we alluded to, you know, you're going to be spending more time. You're going to spend more energy in this case. I don't care how you do it, whether you chop, do this, do that, or whatever. You're going to have to emulsify lens, and you're going to have to emulsify it a lot longer than a milder cataract. And so I'm thinking about protecting the endothelium as much as possible. So I will already have in my mind, so to speak, the idea of using extra viscoelastic at some point during the case.
Would it be fair to say, you know, kind of the threshold that I use, and I like to think about this because I think everybody always makes the decision, when do I need to use an augmented pupillary dilation and when don't I? And I tend to err on the side of I'd rather use it than need it halfway through the case when it's no longer as convenient. And so I actually use what I call the ask myself the question threshold. If I ask myself the question, I probably ought to have it.
That's a great way to put it. If you're thinking about it, you know, take an extra club. There's the water. So let me just touch on my take with the Malyugin Ring. So this is the 6.25 size Malyugin Ring, which is what I use standardly. It comes in a 7mm diameter as well. I've not found my situations require using a bigger one. As I said, the main thing about this device, and here it is in the packaging, so it's withdrawn back into the inserter before you remove the inserter from the container that has the ring in it. So there's the finger piece that just pulls the thing back, and as I push the finger forward, you can see the entering eyelet of this at the anterior end of it. The tip of the instrument I'm going to use to put this in is basically a Lester hook, and this is a modified Osher MST manipulator that's used to manipulate the device in the eye. But this is an extra add-on. I mean, MST has this, but you can use a basic Lester hook. You can struggle with a Sinskey hook if you like, but it's nice to have a push-pull type of mechanism to do this. So the thing is retracted into the tip of the device, and it's placed into the anterior chamber through your incision. I do this routinely through 2.4mm incision. It's easy to get this thing through that size incision.
Gary, just a quick question. If you know, do you change your approach if the pupil is very, very small and there's post-synechiae? I mean,
That's a great question.
What variations do you do in terms of just inserting it right off the bat?
So yeah, that's a great question. I think that to use this effectively and facilitate its use and take full advantage of it, it's important to release any pupillary adhesions that exist ahead of time. So at the time that I'm instilling viscoelastic in the anterior chamber, as I'll show you in a moment, I would release posterior synechiae with my viscoelastic cannula, and I think it's not a bad idea if you want to stretch the pupil a little bit, if you have a fibrotic, phimotic pupil, to allow this thing to go in more easily. So you're just not pushing a fixed pupil in all different directions. Is that what you're alluding to, Mike? I mean, I think that's important.
And going along with the word pushing, is this case under topical or is this case under a regional anesthesia?
So topical tetracaine and augmented with intracameral 1.5% non-preserved lidocaine.
One of the things that I find is that if I'm doing one of these cases under topical anesthesia, during the injection process, that stage that you see on the left of the slide that's up there right now, during that moment, sometimes the patients can feel just a little bit of a pressure-like sensation. And it's not usually an uncomfortable sensation, but it is sometimes a noticeable sensation. So I will often warn my patient in advance, you're going to feel a little pressure for a second.
So as you see here, the device is, with the finger button, the device is pushed forward. I typically will engage the distal eyelet and not worry too much about the lateral ones. And once the device is in the eye, then use the manipulator I just showed you to put each of the eyelets on the pupillary margin, engaged as you see here. And you know, I take my hat off to Boris for this. This has actually changed the game so incredibly, hugely for so many of these cases that I do. But the beautiful thing about this is when I first saw it, I saw this square device and said, well, you know what? Iris retractors gives us a square pupil as well. But this has 8 points of contact with the iris. It has a point of contact where each of the eyelets are, and then it has a point of contact where each of the rods in between the eyelets cross over the iris. So it's absolutely a roundish pupil, and that's one of the other nice things about it. And you can move the pupil around with it. You put it in and you pull it back towards you, so you can center the pupil over the area that you want to do the rexus. The last move is usually positioning the trailing eyelid on the iris, as you see here. So I'm just going to let me show you this. So here's the viscoelastic. Just enough to deepen the chamber centrally. That's the key point. I haven't used my full-on amount of viscoelastic at this point. I've just made enough space to place the device. So in this case, I don't have posterior synechia. This is a 2.4 millimeter incision. I'm going to engage the distal, and you see what I'm doing? I'm backing the instrument up as I push the device forward. Now the distal portion of the pupil will disappear from view to some extent, but that's okay. What I have done at this point is I've rolled left and right as I've inserted the device to catch the 2 lateral eyelets on the pupil as well. Totally unnecessary. I mean, you can put the whole thing in the anterior chamber, not engage it at any point on the pupil, and then go in with the manipulator and put each of the eyelets on there. But this is typically what I'll do with a pupil that facilitates this. So as I'm injecting the device, I'm also backing the instrument out of the incision so that the device is not being pushed too far distally. I'll engage this is actually a simple Lester hook here. This is not the device I showed you earlier, but this is just a simple Lester hook, and that's used to, again, position the trailing eyelet, and then I can pull the pupil to where I want it to be. Now in this case, I've used viscoelastic at this point. I will typically add viscoelastic before I start the rexus, but in this case, I want to stain the capsule. So I'll use a sort of painting technique with the trypan blue. I'll place my cannula underneath the viscoelastic agent as much as possible and just essentially inject a little trypan blue and stroke the capsule in a hockey stick style with the instrument to paint the capsule. Last and most importantly is I'm not going to do anything in manipulating until I've finished my full expansion of the anterior chamber and corneal endothelium with protection with the viscoelastic. In this case, it's a viscoat that I'm using, a dispersive viscoelastic that I use for this particular case. I typically will use a simple cystotome to perform my rexus, as you see here. I've got a beautiful pupil. I've got a stained capsule. I mean, so far, this is just simply a walk in the park. So I'll use a little hydrodissection here to make sure my lens is fully mobile. And at this point, just stop the video here for a moment. You know, you're going to hear everybody talk about their phaco technique for a hard lens and whatnot. And I'm just going to tell you what I do briefly. I'm a big fan of removing as much lens as possible as far away from the cornea as possible, particularly if I'm going to be using more energy than I would in a typical case. So I call the area behind the anterior capsule, I call it the free parking or the free phaco zone. You can phaco all day long behind the anterior capsule. It's when you bring those pieces anteriorly and you start phacoing in the iris plane and anterior to the iris plane that you're really going to be challenging your endothelium. So comments on this, guys? I'm going to show you my technique, and it's probably completely different than what you do, but I think what's important is what we're thinking about at the time we're doing it.
I think that's a great comment. I think the more energy that you deliver further away from the cornea, the better off you are. I'm noticing as you're doing a couple of your passes there that you're getting those sleeves of dense material. That shows that this isn't a 4+ lens, this is a 6+ lens, so I think you underestimated.
You know, and I agree with debulking there in the center. I mean, I think not only do you want to be away from the cornea, but you want to ensure that your crack is full thickness, avoiding those posterior leathery fibers from attaching both heminuclei. The key point here is to get that split down the middle, to mobilize those heminuclei. And I think chopping, I know I'm a big chopper, but these ones I do exactly what you're saying, where I basically groove fairly deep, and I'll debulk and then maybe perhaps chop after that. So I like that. And I like the fact that you didn't just inject the trypan blue right at the beginning of the case. because that would only stain the central small pupil area, but you've been able to stain the entire capsule after the Malyugin ring was inserted. So I love putting the trypan blue under viscoelastic after the pupil has been manipulated. I think that's a great pearl.
So exactly as he said, I like deep and wide grooves. I'm taking out as much lens as possible before I even start to bring any of it anteriorly. If I do a deep, wide grooving process like you saw here, and then switch, at one point I switched from a pure torsional to adding some longitudinal phaco, but at this point I'm going to go back to pure torsional, and what you'll notice is I've utilized the phaco energy I needed to remove the lens while it was posterior, and now I've got very small quadrants left behind. I'm in pure torsional mode here, and the whole case is basically done as much as possible in that free phaco zone. And
Gary,
so,
I saw that you cheated and added extra OVD during the case.
Very good.
that's exactly right. So after I've done the deep grooving and before I start do the quadrant removal, as Mike pointed out, you saw the viscoelastic go in there again and simply re-coat. And the amount of time that I took to do this compared to you guys, probably my viscoelastic had expired by the time I got to that point, so I needed to add some more. But so essentially, at this point, but you'll notice that during the entire procedure, the pupil, the iris, wasn't even in the game. It was just taken off the table. And so to remove this device now, and you got to remember to remove it, because sometimes you just forget that it's there. Everything else is just so smooth. So I've disengaged again with the same instrument, the eyelets. And what I simply do is disengage the distal one first and just disengage all of them, if you will. I put the instrument back in and just engage the finger of it, if you will, and just reverse the process. You don't need to take the whole thing back up into the sleeve. Sometimes one of the eyelets will get caught on the edge of that sleeve. And so just to basically get it back in its linear format is all you need to do to get it through the incision. And there's many different ways to remove it. It's a very, very straightforward
Gary,
process.
can you go back to halfway? You can't reverse? Okay. One of the things that he did that I think is really valuable is that in the process of removal, sometimes if you're retracting the device back into the inserter remover tunnel, once the two lateral rings come into the middle and start overlapping each other, you might not have noticed that Gary actually brought that portion into his corneal tunnel. And so the roof of the corneal tunnel allowed those to compress back into the inserter. If you try to do that in the middle of the anterior chamber, sometimes one of those loops might catch on the top of the retracting element and can twist a little bit. So that little step of just bringing it into the tunnel makes 1,000% difference in how easy it goes. And just a quick question, Gary. You said that sometimes you forget. What do these things look like at the slit lamp when you forget?
No, but the typical thing is you'll go back in with your IA, take out all the viscoelastic, and then the scrub tech says, "Are you going to take that thing out?" And you say, "Oh, that's right, I got to take that thing out. Now I need more viscoelastic to put back in there so I can take the thing out." So you have to remind yourself after the IOL is in and whatnot, to stop. Don't go automatically back to your eye. Think about that. And your point, Mike, is right on target. It's not necessary, as I said, to get the whole thing in the sleeve, just as long as you get it folded back in a linear format. But I do use the roof of the corneal tunnel to compress that other thing. So I am going to stop there. I thank you, Ike and Mike, for your comments and whatnot, and so we'll move along in the interest of time. Thank you.